So something I failed to mention in our initial introduction was to mention Dr. David Lawson over there in the corner, because he's the whole reason any of us are here. And we gave him a break today in having to talk because he's been doing these talks for a while. But he's the reason we're all here. He began the melanoma program, I don't know what year, and he's gonna claim not. But he has seen the evolution of immune therapy from vaccines to a lot of negative trials to the things we have now that are really changing outcomes for everyone and kind of changing the ball game. So I see a lot of people in the audience that have probably experienced immunotherapy and experienced some of the complications. So you guys may know more about it than me, having personally experienced it. But I'm going to talk a little bit about some of the terminology you may hear or read about. Immunotherapy is really in the news these days. Talk about some of the commonly used drugs and try to touch on the side effects and questions that we still have. So immunotherapy, what does that mean? It just means stimulating your own immune system to recognize something as abnormal or what we call innate and take it away. So, so using your innate immune system, your normal immune system to detect and destroy cancer cells. And it's probably something our immune systems do all the time that we don't even know about before we get diagnosed with a cancer. So checkpoint inhibitors are drugs that block proteins on immune cells. So your immune cells have natural checkpoints so it doesn't go awry. And they're just part of you. And what our drugs do are kind of intervene on these different checkpoints. So if you hear us talking about checkpoint and checkpoint inhibitors, that's what we're talking about. A lot of these drugs that we talk about are antibodies. Antibodies people think of as fighting different things, but our antibodies are designed to, and they look like these, but they're designed to block those proteins or checkpoints on different cells. Immune modulators help kind of regulate your immune activity, so how intensely your immune system's reacting or not reacting. There's sometimes people call them like hormones or gas or fuel. Drugs like interleukin or interferon kind of modulate your immune system, so how fast it's turned on or off. There's a lot of other things that are out there in the news, from vaccines, which a lot of us are familiar with, so taking a portion of a cell and trying to get your body to react to that. Adoptive cell transfer is something that you may hear about, which is where we take cells from you or from the melanoma, isolate the immune cells and try to grow them in our lab and give them back to people. Your T cells or your lymphocytes are part of that white blood cell count that we talk about, and they are the portion of your cells that are primarily active in fighting cancer cells. TIL is our term for tumor-infiltrating lymphocytes, and those are the cells we see under the microscope of melanoma that are your natural immune cells trying to fight the melanoma. Autoimmune is something we talk about a lot. It's when our immune system is attacking something that's yours, that should be there. It's our immune system kind of going awry and not doing what it's supposed to do. There's also a lot of talk on biomarkers. Biomarkers are something we use to kind of guide therapy or guide decisions that we make. So it's something in biology, either something in your blood, something in the cancer that can predict outcomes. And it's kind of our holy grail of trying to find that perfect biomarker so we wouldn't have to have all these tough conversations. We could just say, oh, look, it shows that, and this is what we're supposed to do. So just switching our terminology, just talking about some of the drugs. Some of you guys may be very familiar with these drugs, but I find, I don't know why, but we create 3 names for every drug and create confusion for everybody. But these are a lot of the immune therapies that are in the news and things that we will talk about. And so ipilimumab was one of the first drugs ever approved for melanoma patients that actually changed how people did and made people live longer. The brand name is Yervoy. You'll often hear us call Ipi because that's just too long. Nivolumab is Opdivo. and you'll often hear us call it Nivo, all the same thing. Pembrolizumab is a very similar drug to nivolumab. The brand name is Keytruda, and you might hear us call it Pembro. So sometimes we combine these drugs, so we'll call it Ipi-Nivo. I've heard people call it the combination or the regimen. So a lot of times this is what we're referring to. There's other drugs that we use in melanoma. So basically this is kind of interferon, which thankfully we don't talk about too much anymore. But intron A, or you may see it abbreviated like that. There's a pegylated interferon. Pegylated just means kind of longer acting, so you can give it less often. Brand name is Silotron. T-VEC is just approved not too long ago, and somebody in the audience, about Keith, I don't see him right now, knows what T-VEC stands for, and it's way too long. But Imlygic is the brand name. High-dose interleukin 2, or IL-2, is another immune therapy that you may hear about. But the lingo gets complicated, and sometimes every one of us probably uses a different version of how to say that. When I was a resident, they used to beat me for saying brand names, so I never say brand names. And now I talk to patients, and everyone's like, what is that drug? Because they know it by the brand name. So feel free to always stop your physician and ask them if you don't know. Don't be embarrassed. We often forget, and we use these names all the time. So definitely stop us when we're starting to use lingo that is not appropriate. Just sometimes visuals of how the immune system works is sometimes helpful. So in your body, you have these T cells and these other immune cells we call antigen-presenting cells. And what happens is these two have to come together to make your T cell do what we want to do. So, and then this other receptor comes to the surface. So that's kind of what happens when a T cell is activated, but this is their break. That happens in your immune system all the time. When it's fighting an infection, when it's fighting other things in life, you have a natural break. And what we do with a drug called Ipi, or Yervoy, is the brand name, is just block that break. And so your T cell can come back on. The PD1 antibodies are the flip side of it. So PD-L1 is something that tumor cells are pretty darn smart, and they try to find a way to get around the immune system. Their whole job is to live, right? And so what it does is it kind of binds to an area on your immune cells and sucks the gas out of it. And our term we use is exhaustion. So there's no gas in this T cell. It can't do what it's supposed to do. And these drugs like this that we call PD1 antibodies block the ability for this to happen. So you essentially put the gas back in the system to get your T cells on. So all these drugs, really ultimate goal, get that T cell on so it can do what it's supposed to do. But the problem when we do all this cutting breaks and refueling the gas is those breaks were there for a reason. And I see people in the audience today that have experienced some of what we call immune-related adverse events, which is basically our fancy term for side effects. And they all these immune drugs essentially have the same list of side effects. They just happen at different rates for each drug. And essentially, all the side effects are when we attack something normal in our body. So the severe toxicities happen about 20 to 30% of the time with the Ipi drug, about 10 to 15 with the Nivo or Pembro. The combination has a much higher rate, with 50% of people having at least one, and many of these patients will have multiple side effects. Treatment, a lot of times we use steroids, drugs called prednisone, that people are on for several months. But some people will have very severe cases that are not responsive to steroids, and there's some other drugs that actually dampen your immune system that we can use in these refractory cases. But the biggest thing to know about side effects is everyone, every time I see a patient with a side effect, when you're dealing with cancer, Keith said it earlier, a lot of times we get a pass, and you guys say, it doesn't matter, I don't care if it's fighting the cancer. And the one thing everyone wants is more treatment. But a lot of times when people have these severe side effects, we can't go on to more treatment. But there's been no evidence that treating these side effects or stopping treatment because they're severe affects how people do. And many of these patients actually do very well from a cancer standpoint. And so just every time they want me to give them more drug, and I'm like, I can't believe you want more when I did this to you. And the truth of the matter is we don't know how much people need. And if you're having some of these side effects, it may mean your immune system's already on and that you don't need more. So it's okay to stop, and it's okay to treat the side effects. Because I've had patients tell me before, I didn't want to tell you that I was feeling bad because I didn't want you to stop the drug. But honestly, treating these side effects and treating them appropriately have no effect on how people do overall from their cancer. So this is kind of a list of these autoimmune side effects that we get. So when we attack self, when you attack the gut, you get diarrhea, which we call colitis. The skin, you can get dermatitis, which is itchy and red, or something called vitiligo. Vitiligo has been a marker for people that actually do very well from melanoma since ages, since the beginning of interferon or all those other older immune therapies that we used to use. Vitiligo is where you lose pigment in your skin. So people remember Michael Jackson, but it can not only just be in your skin where you have white patches, it can be in your hair, it can be in your eyelashes. And that's when our dermatologic colleagues, we're very excited. We're actually going to have a dermatologist within Winship that can help us manage all these. When it attacks your lungs, you might feel short of breath, you might have coughing, and that's what we call pneumonitis. Pituitary. The pituitary gland is an area in your brain that controls all your hormones. So for men, testosterone, females, your cycle, those types of things, your normal steroid, your thyroid gland, it can attack that. And so we have to replace all those hormones with pills. Same thing with your thyroid gland directly. When it attacks part of your pancreas, people can develop actual diabetes. All these, what we call endocrine side effects, are permanent from these drugs versus these other ones that tend to be very reversible after appropriate treatment. So nerves, it's a rare but serious side effect. If it attacks the nerves, people have numbness and tingling in their hands and feet. They can develop diseases that we call Guillain-Barré or myasthenia gravis. That can cause weakness or numbness in parts of the body. So those are just kind of an overview of things people can experience. Many people have none of these, but many people also experience these side effects. So it's very individual. And something I may have told a lot of you is statistics tell you nothing about what will happen to you. So no matter what percentage I say, whether it's 50%, whether it's 10% or 1% of having these, if it's you, it's you. And so when you go into something, I say you always prepare for the worst and hope for the best. And maybe you will be the one that never has it, but to make sure we work together as a team to get you through it if you do happen to experience it. So these are the questions I think my patients ask themselves, or questions that I ask all the time. And I kind of wanted to go through some of this individually. So can I be cured? That is the hardest question to answer. I think the answer is yes. I think there are people with stage 4 melanoma that are cured. I say I don't know that till people can die of nice old age and heart attacks and strokes and all the normal things that people get outside of cancer. And there's more and more people that I think are cured. And the question is it's never high enough? And there's many more patients that I think may not be cured, but will be able to live with their cancer. And Dr. Delman spoke of this earlier. Cancer is becoming more like a chronic disease that people live with. It doesn't have that connotation when you hear that word, cancer, but it's true that there are people that live with it and that change therapies, but they're living with it. And that's the most important thing. But I do think there are individuals that are cured that have what we call long-term survival. All these drugs are new. So they haven't been around for 50 years to really tell you whether people are cured. They've been around. The oldest one, IPI, was approved in 2011. And so all these other drugs are newer. And so even back in the days of high-dose IL-2, there was a cure rate. In this, we have 30 years, 20 years of data that 5% were cured then, but 5% is too small of a number. And we're steadily improving on that number. The combination of using both drugs like Ipi and Nivo or together, we think is going to be higher, but we don't know. And there's a lot of debate, and we'll go over that later, because the follow-up for the combination is only a couple of years, so we just don't know. Another question I get asked a lot is there a difference between Ipi and Pembro? Not that I can tell. I don't know if these guys have a different, they're both shaking their head too. I can't tell a difference. Having done even the early trials with these drugs, the data seems very similar. I think they can be used essentially interchangeably. Is there a test to tell me which one of all these choices? I told you about things that have higher side effects, things that have lower side effects. What is the best choice for me? And that's when that term biomarker comes in. Is we all want that test, but the real answer is we're working on it. We're not quite there. There are a lot of studies showing that if I biopsy you after treatment and we see certain responses, that can be predictive, but that's too late in my book. If I have it after, if it's later, then I've already made my choice, so it didn't really help you. There's a lot about this thing called PD1 testing. It's a test that can be done on your cancer cells before you get treatment. It hasn't been the greatest test. It's what we have the most data on, but it's not perfect. There's people that are quote-unquote negative that respond to these drugs. There's people that are positive. So from my standpoint at this time, we can't use it completely. It's still kind of an area of research that we need to get better on. And we need that marker. We desperately need that marker. The other question that comes up a lot is 2 better than 1, meaning giving 2 drugs better than 1. Really depends on who you ask. Together has a high shrinkage rate, but a lot more toxicity rate. So could doing one after the other be just as good? There's a lot of data coming out there. If you use one drug and it doesn't work, can you go to 2 drugs? That's, again, an unknown field. So a lot of these questions are really great questions that I don't have answers to yet. Hopefully in the upcoming years we will. How much toxicity is acceptable? And I think this is where you guys can really help us, because, it's a different answer for every patient. And honestly, sometimes it's different between the patient and the caregiver of what people find acceptable and what people don't. We used to think age would be a really good predictor of, if you're older, you may not want toxicity. If you're younger, you'll probably take more. That hasn't necessarily been true. There's, I think it's an individual decision. If you have less disease, less risk makes sense. I think a major question for me is if I make you sick, am I going to be able to make you better? Am I going to be able to get you back? This is a term we call performance status. And the weaker you are to start, the harder it is for us to get you back to what you were. And I think that is also a major question. And I think this is a conversation to have with your physician to really talk about what's acceptable to you and what's acceptable to your family and what we can get you through. And are we creating new chronic diseases? This is something that kind of keeps me up at night. I beat myself up like I've taken away cancer, but I've given you something else that you're going to have to live with. And those are things that are pretty serious, like type 1 diabetes, like thyroid disease, like vitiligo, especially in our patients that are darker complected or Asian or African American. I mean, these are, though cosmetic, very serious and can be disfiguring for those patients. And is this an okay trade-off? And I think that's really where we need your input. And is that an okay trade-off? Because for some people it is, for some people it may not be. And I think it's something that we worry about a lot as we are having people live with melanoma and live a long time with melanoma, how creating these new diseases is going to affect you. So What do we do? All this news, all this press of how great all our drugs are becoming. Things happen and they don't work. And so we'll talk about trials in just a second, but that's where we need to move forward. We've come a long way, but we still have a long way to go. There's older therapies that we tend to think about, oh, the new, the future, but sometimes those older therapies still work, and to consider. And there's a lot of different drugs on the horizon that are coming out that will hopefully this talk will all be out of date in a couple of years, and we'll have even greater and better numbers and more people surviving. Those are my children and my dog in the back. And that, thank you guys for coming, but I have